Okay, welcome back to the deep dive. We're surrounded by this microscopic world, right? Constantly interacting with it on our skin and our gut, even the air we breathe.
It's everywhere.
Think about it. Every breath, every touch, every single meal involves an exchange with like trillions of tiny organisms. And while we hear a lot about scary sounding diseases, the actual process underneath, the biological thing that makes a lot of them possible, well, that's way more common, more fundamental. We're talking about infection.
That's absolutely right. Infection is that constant interaction between us, living organisms, and microbes. And understanding that balance, the mere presence, the activity, maybe the multiplication of microbes on us or in us, it's just foundational. It really is the starting point for thinking about health and disease.
Exactly. And for you, our listener, especially since you're diving deep into dentistry right now, this isn't just some abstract biology lesson. Understanding this stuff is profoundly, fundamentally critical.
It really is.
Your future day-to-day practice. It's going to involve navigating this complex microbial world in the most direct, hands-on way possible. Mm-hmm. You'll be right there, working in an environment just teeming with microbes, doing procedures that, well, they can disrupt tissues, and you need to know how to protect yourself, and of course, your patients, from potential harm.
Which is precisely why we're dedicating this deep dive to the science of infections. We've got this piece of source material here. It explores the fundamental types, how things get transmitted, the virulence factors, all that stuff associated with infectious agents.
Right.
So our mission today, really, is to unpack this source, to go beyond just the definitions and pull out the most crucial insights. And we want to make sure we spend extra time highlighting the concepts, the facts that are going to be most impactful, most relevant for your specific journey as a future dental professional. We want to give you that solid microbial bedrock you need.
Okay, perfect. So let's start right at the beginning, because our source makes a very, very clear and crucial distinction. It really sets the stage for everything else we'll talk about. Infection versus infectious disease. They're definitely not the same thing, and getting that difference is key.
Yeah, that's a really important starting point. The source defines infection as the process where a microorganism, could be a bacterium, virus, fungus, maybe a parasite, enters the body, starts to increase in number, and might cause damage to the host tissues.
Might cause damage. Oh.
Right. It's described essentially as the simple lodgement and multiplication of a parasite, in or on the tissues of a host. It's about the presence and the activity of the microbe itself.
Okay, so infection is basically the microbe showing up, setting up shop, multiplying. It's about them being there. But then what makes that presence turn into actually being sick?
That's where infectious disease comes in. According to the source, infectious disease is described as this rare consequence of infection.
Rare? That's surprising.
It is, isn't it? It's a critical insight. The symptoms we usually think of when we say we're sick from an infection, the fever, pain, swelling, maybe not being able to use a body part properly, they only show up in those relatively rare cases where the initial infection actually progresses to a state of clinical disease. And crucially, the source states these symptoms are mainly caused by two things. The microbes producing harmful substances called toxins. It specifically mentions endotoxins and exotoxins, and importantly, by triggering the host's own inflammatory response in those affected tissues.
So this means you could absolutely be infected, like have microbes present and multiplying inside you, but show zero symptoms, not feel unwell at all.
Absolutely. The source really drives this home by emphasizing that infection itself is common, almost a natural biological event happening constantly as we interact with the microbial world around us. But developing actual clinical disease from that infection, well, that's not always guaranteed, not by a long shot.
That's a huge aha moment, isn't it? Just because microbes are present doesn't automatically mean sickness.
Exactly. And think about the oral microbiome. This is going to be one of the most important microbial environments you deal with constantly. Your mouth is just teeming with billions of microorganisms, bacteria, fungi, even viruses living on tooth surfaces, gums, tongue, the lining of the mouth.
It's a whole ecosystem in there.
It really is. And most of these are commensals, meaning they live there without causing harm, or sometimes they're even mutualists, actually providing benefits. That state, just the presence and multiplication of these microbes, fits the source's definition of infection in its broadest sense. But that's the baseline state of health, right? Not disease.
Right. It's the normal flora. It's supposed to be there.
Yeah.
So the really crucial question this distinction brings up, especially for someone going into dentistry, is what makes that balance shift? When do those microbes, maybe the ones normally living there harmlessly, or maybe new ones introduced from outside, cross that line? Go from just being present and multiplying infection to actively causing the kind of damage that results in diseases like, say, cavities, periodontal disease, or an oral abscess. Those are all infectious diseases.
Precisely. It forces you to think about the conditions. What changes? Is it something about the microbe itself, or maybe something changes in the host's defenses? This immediately takes you from just theoretical microbiology to practical clinical thinking. You're constantly evaluating the microbial situation in the mouth and assessing the risk of it tipping over into actual disease.
Okay, that sets the stage perfectly.
Yeah.
Let's really dig into this more, using our source as the guide. Now that we have a handle on what infection is, basically, microbes present and multiplying, let's look at the many different types of infection the source describes. This classification, it helps us understand the journey, the impact of an infection.
Yeah, the source gives us a pretty comprehensive list, actually, 14 different types. It's a valuable framework for categorizing these things, helps us think about where they come from, the timing, how they might spread.
Okay, let's go through them like the source does. Number one is maybe the simplest. Primary infection.
Yeah, very straightforward. This is just the very first time a particular host encounters a specific microorganism in a way that leads to infection. The initial encounter, the first time that microbe successfully establishes itself in that person.
Simple enough. Then comes reinfection. The source says this is meeting the same organism again. What does that tell us? About immunity, maybe.
Well, it suggests a couple of possibilities, doesn't it? Either that first primary infection didn't really stimulate a strong, lasting protective immune response, or maybe the host's immunity did develop, but it faded over time. So they become susceptible again to the very same pathogens setting up shop once more. It kind of points to the limits of the host's immune memory for that particular bug.
Okay, now this next one. This feels really interesting and very relevant clinically, especially when you think about patients who might have other health issues. Secondary infection.
Oh, absolutely. This is an incredibly common scenario you'll see in healthcare. A secondary infection happens when a new, different organism manages to establish an infection in a host, specifically because that host's resistance, their immune defenses, are already lowered significantly by a pre-existing illness, often another infection.
So one infection basically paves the way for a different one to take hold.
Exactly. The first illness weakens the system, makes it vulnerable. Think about someone who's really run down by a bad case of the flu, a virus, right? Their immune system is totally focused on fighting that off. Their body's stressed.
Right.
That compromised state could make them much more susceptible to, say, opportunistic bacteria that might normally be harmless or easily dealt with. And those bacteria then establish a secondary infection, maybe like a bacterial pneumonia setting in after the viral flu or a sinus infection.
And this is super relevant, because the patients you'll see in the dental chair, they don't exist in isolation. They might already be dealing with other things, maybe diabetes, autoimmune conditions, maybe they just had surgery, or they have some other chronic infection, all things that could lower their resistance.
Precisely.
So a seemingly minor dental issue, or even a routine procedure, could potentially trigger or worsen a secondary infection if you're not aware of that patient's compromised state.
Exactly. You have to be vigilant. You need to recognize that a patient's overall health status deeply impacts their susceptibility to infection, including these secondary ones that can pop up and complicate things, whether it's related to an oral condition or a dental procedure.
Okay, number 4 is a big one for healthcare, and especially for dentistry. Cross-infection. The source defines this quite specifically.
It does. It gives a very clear, clinically focused definition. Cross-infection is described as the transmission of infectious agents happening specifically within a clinical environment, meaning patient to patient, or crucially, patient to healthcare staff, and vice versa. It also mentions getting a new bug from another host or source when you're already sick, but the main emphasis is definitely that healthcare setting spread.
And it directly mentions transmission routes, things like contact, fomites, airborne spread, right in the context of cross-infection. This has, well, it has extreme non-negotiable relevance for dentistry, doesn't it?
Paramount. Yeah. Absolutely paramount. Think about it. Infection control protocols in any healthcare setting, and definitely including a dental clinic, are designed almost entirely around preventing this exact thing, cross-infection.
Right.
Think about the pathways the source mentions. Patient-to-patient spread via improperly cleaned or sterilized instruments. Those are the fomites, the contaminated objects. Patient-to-staff transmission through things like needle stick injuries or those aerosols generated during procedures. staff-to-patient transmission from poor hand hygiene, maybe contaminated gloves, or, again, improperly handled equipment. This type of infection, and really understanding how it spreads through those specific routes. That's the absolute bedrock of your daily practice. It's about the safety of your patients, your team, and yourself.
It's like the invisible enemy you're constantly fighting with every sterilization cycle, every hand wash, every mask and glove change.
That's a good way to put it. Recognizing it as a specific type of infection, one that originates from the clinical environment itself, really underscores the unique risks involved in providing care.
And related to that, especially in the broader hospital context, is nosocomial infection, often called hospital-acquired infection, or HAI.
Yes, this is basically a specific subcategory of cross-infection, one acquired in hospitals. The source defines them as infections that develop in a patient after they've been admitted to the hospital, ones that weren't already present or incubating when they came in. And they make a point that these can even show up after the patient's been discharged. Common examples mentioned are things like urinary tract infections, respiratory infections, surgical wound infections.
Now, a dental clinic isn't exactly a hospital ward, obviously, but the underlying principles for preventing these nosocomial infections, they seem directly applicable, right?
Oh, completely. It's all about understanding that the healthcare environment itself can be a reservoir for pathogens, and the people within that environment, the patients, might be more vulnerable. It just reinforces the absolute necessity for rigorous hygiene, cleaning the environment, sterilizing instruments, using barrier precautions like gloves and masks.
Same concepts, different scale.
Exactly. The ways infections spread in hospitals, contact, air, contaminated equipment, those are the same things you battle every day in a dental clinic. It's the inherent risk of bringing potentially sick or colonized people together in one place with shared equipment and staff.
Then there's iatrogenic infection, that term.
Yeah.
It sounds like it's pointing a finger directly at the doctor or dentist.
It is, pretty much. The source definition says iatrogenic means physician-induced, or more broadly, healthcare provider-induced. It refers to an infection that results directly from some form of medical or dental therapy, a treatment, or maybe an investigative procedure.
And this has incredibly direct relevance for you, the listener. Think about it, so many dental procedures. By their very nature, injections for anesthetic, pulling teeth, root canals, even just placing fillings, they involve breaching the body's natural barriers. You're getting past the oral mucosa, maybe into the tooth structure, accessing deeper tissues.
Yep, you're going inside.
So if infection control protocols aren't followed meticulously, the procedure itself could accidentally introduce microbes, maybe from the patient's own mouth surface, maybe from the air, the instruments, or even the provider, into those deeper, normally sterile areas.
It just highlights the huge responsibility that comes with doing invasive procedures. Every single time you pick up an instrument that's going into the patient's mouth, you have to be absolutely certain that it's not going to introduce pathogens that could cause one of these iatrogenic infections. Sterile technique isn't just a suggestion, it's how you prevent causing this specific type of harm.
Very clear. Okay, moving on. The source talks about subclinical infection, also called inapparent infection.
Right. These are infections where the microorganism is present, it is multiplying, maybe even causing some changes at the cellular level, but there are no obvious clinical effects, no symptoms the patient notices, nothing immediately apparent to a clinician just looking or asking questions. The infection is essentially silent.
But the source makes a really critical point about these silent infections, doesn't it?
It absolutely does. It specifically points out that even though there are no visible symptoms, people with these subclinical infections can still transmit the infectious agent to others.
That's huge.
Yeah.
It means you can't just rely on whether a patient looks sick or says they feel fine to know if they could potentially spread something.
Exactly. Someone sitting in your dental chair for what seems like a routine cleaning could be asymptomatically carrying a virus or bacteria that could be spread through aerosols generated during that cleaning or by contact. This fundamental fact is a core reason behind the whole concept of universal precautions in dentistry.
Which means?
Treating every single patient as if they could potentially transmit an infection, regardless of their apparent health or what they tell you. It shifts the focus from trying to guess who's infectious to making sure your procedures and your environment are safe for everyone, every time.
Okay, that makes sense. Next up is latent infection.
This refers to a state where a microorganism gets into the host, establishes itself, but then it kind of goes into hiding. It enters a dormant or hidden phase. The organisms might just hang out in specific cells or tissues, not actively multiplying or causing symptoms for potentially long periods.
But they're still there.
They're still there, and they retain the potential to reactivate later on, start multiplying again, and cause clinical disease. This often happens, the source notes, when the host's resistance drops for some reason. The classic example given is herpes viruses, which can be reactivated by things like immunosuppression.
And this is super relevant in dentistry because oral herpes, caused by the herpes simplex virus, HSV, that's a very common latent infection, right? Cold sores.
Exactly. After the initial infection, which often happens in childhood and might even be subclinical, the virus retreats into nerve ganglia. It just sits there. Then, periodically, it can reactivate. Triggers can be things like stress, maybe sunlight exposure, hormonal changes, or indeed immunosuppression from illness or medication. And that reactivation leads to the recurrent cold sores or fever blisters you see. So understanding latency explains why patients might get these recurring oral lesions and how their underlying status, stress levels, immune health is directly linked to when these visible and importantly contagious lesions appear. It impacts treatment decisions too, like maybe postponing elective dental work if a patient has an active herpetic lesion to avoid spreading it.
Good point. Okay, then we have atypical infection.
This one's pretty straightforward. It's simply an infection where the clinical presentation, the signs and symptoms, are significantly different from the usual or textbook picture you'd expect for that particular pathogen. It just doesn't look typical, which can sometimes make diagnosis a bit trickier.
Right, throws you off the scent. Okay, the source then gives us several types based on how infections spread within a population or geographic area. We've got endemic, epidemic, and pandemic. These give us more of a public health view.
Exactly. Endemic infection describes a situation where an infection is constantly present, but usually at a relatively low predictable level within a specific population or geographic region. The source uses malaria in certain tropical areas or typhoid in some developing countries as examples. It's just part of the background noise of infectious disease in that place.
An epidemic, then, is a definite increase.
Yes, an epidemic is when you see a significant, often sudden increase in the number of cases of an infection above what you'd normally expect for that population or area, or during a specific time frame. The source mentions things like seasonal flu outbreaks or outbreaks of meningococcal meningitis. It's a clear surge that stands out from that endemic baseline.
And finally, pandemic, a term we're unfortunately all very familiar with now.
Yeah. A pandemic is essentially an epidemic that's gone global. It's an infection that has spread across vast geographical areas, maybe multiple continents, affecting a large proportion of the world's population. The source lists HIV and SARS as examples, and obviously COVID-19 fits this definition perfectly. These terms just give us a scale for understanding the reach and impact of infectious agents on populations.
Okay. And the last way the source categorizes infections is based on their location within the body. Localized infection versus generalized or systemic infection.
Right. A localized infection is one that stays confined to a specific site or organ in the body. The source gives examples like an infection limited just to the appendix or the tonsils. It does note, though, that even if the microbe itself is confined, the local infection can still cause generalized effects, like maybe a fever or feeling unwell, but the main action, the microbial activity, is restricted to one spot.
And the source gives examples like boils or cellulitis, often from staph bacteria, which start and mostly stay in one area of skin or tissue.
Correct. And this concept is incredibly relevant to dentistry because so many common oral infections start as localized problems. Think about an abscess forming at the tip of a tooth root, a periapical abscess, or an infection just in the gum tissue around one-tooth gingivitis or maybe localized periodontitis, or even a boil-like infection in the soft tissues of the mouth. Understanding how these infections usually stay contained, maybe within the jawbone or oral tissues, and importantly, what might cause them to break out and spread, that's fundamental to diagnosing and managing them effectively.
And the flip side is generalized or systemic infection.
This is where the infectious agent spreads throughout the whole body from where it first entered. The source mentions different ways this can happen, spreading directly through adjacent tissues, traveling through the lymphatic system, or, very significantly, getting into and spreading via the bloodstream.
So putting all these types together, from the first encounter primary to infections influenced by prior health secondary, those spread specifically in clinics. cross-infection, iatrogenic,
Right.
the hidden ones, subclinical, latent, and then classifying by location, localized, generalized, or population spread, endemic, epidemic, pandemic.
Right.
It really gives you the essential vocabulary, the framework for thinking about the microbial challenges you're going to face day in and day out.
Absolutely. Diagnosis, treatment planning, prevention strategies, even predicting how a disease might progress. It all depends on correctly identifying and understanding the type of infection you might be dealing with. It's like learning all the different characters and plot lines in the big story of how microbes and hosts interact.
Okay, so infections come in all these different shapes and sizes, local or spread out, silent or obvious, coming from inside or picked up from outside. But how do these microbes actually get from wherever they're hanging out to a person they can infect? Our source material clearly lays out the crucial components needed for successful transmission.
Yeah, transmission isn't just one thing, it's more like a chain. The source breaks it down into 3 essential links, and all 3 have to be there for an infectious agent to spread effectively and potentially cause disease. You need a reservoir, a mode of transmission, and a susceptible host.
And if you can break any one of those links,
You stop the spread, exactly. The source spends a good amount of time detailing the first 2 links, where the microbe lives, its home base, and then how it actually travels from there.
Okay, let's start with the reservoir.
Yeah.
What does the source tell us about where these organisms live and multiply?
The reservoir is defined as the place where an infectious agent normally lives, multiplies, and from which it can potentially be transmitted to a susceptible host. It's their natural habitat where they maintain themselves. And importantly, they might or might not cause symptoms in that reservoir itself.
And the source gives several examples of what can act as a reservoir.
Yes, several key ones. Probably the most common and significant reservoir is often humans. This includes people who are actively sick with a clinical infection. They're often shedding lots of microbes. But critically, going back to what we discussed earlier, it also includes carriers.
The silent spreaders again.
Exactly. Carriers are individuals who harbor pathogenic microorganisms and can transmit them, but they don't show any signs or symptoms of the disease themselves. The source even breaks down different types of carriers. Healthy carriers, never symptomatic, convalescent carriers, recovered but still shedding, and temporary or chronic carriers, shedding for different lengths of time.
For a dental professional, thinking about carriers must be vital. A patient could look perfectly healthy, feel perfectly healthy, but be harboring something in their mouth or respiratory tract that could be transmitted during a procedure.
Absolutely critical. You simply cannot rely on a patient's appearance or self-report to know if they pose a transmission risk from being a human reservoir.
Okay, what other reservoirs does the source mention?
Well, there are animals. These are the source for zoonotic diseases, the ones that jump from animals to humans. The source gives examples like rabies from infected mammals, or plague, which can be carried by rodents. Then there are insects or arthropods. They can act as reservoirs themselves or often as vectors transmitting diseases. They might do it mechanically, just carrying the bug on their body parts, or biologically, where the pathogen actually multiplies inside the insect. The source mentions ticks transmitting relapsing fever as an example.
What about the environment?
Yep, soil and water are listed as important environmental reservoirs. Certain pathogens are really hardy and can survive for long periods outside a host. Think about bacterial spores, like those causing tetanus or gas gangrene. They can persist in soil for ages. And contaminated water, that's a huge reservoir for many intestinal pathogens. The source lists Shigella, Salmonella, Vibrio cholera, which causes cholera, plus viruses like polio and hepatitis A.
And finally, food.
Right. Food can become contaminated with pathogens, maybe from an animal source, a human handler who's a carrier, or the environment. And then that contaminated food acts as both a reservoir and a vehicle for transmission, leading to things like diarrheal diseases and food poisoning, as the source points out.
So identifying the reservoir is often the first critical step in stopping transmission, understanding where the pathogen is coming from.
It gives you the starting point for control measures.
Okay, which brings us to that second crucial link. The modes of transmission. Once the microbe is in its reservoir, how does it actually make the journey to a susceptible host? Our source outlines several key ways this happens.
The first big category is contact transmission, and this is broken down further.
Into direct contact first.
Direct contact is exactly what it sounds like. Physical transfer of the infectious agent directly from an infected person, or maybe an animal, to a susceptible host through close physical interaction. The source lists examples like touching, kissing, sexual contact, or direct physical contact with infectious sores or lesions. Things like the common cold, staph skin infections, and sexually transmitted infections. Gonorrhea, syphilis, AIDS, herpes type 2 often spread this way. It's immediate, person-to-person touch.
And then, just as important, maybe even more so in some settings, is indirect contact.
Right. Indirect contact involves the transfer of the bug through some kind of intermediate object or surface. The source specifically calls these inanimate objects fomites.
Fomites, okay.
Examples given include things like contaminated clothing, handkerchiefs, or, very importantly for you, contaminated instruments.
This mode, indirect contact via fomites, it has massive relevance for dentistry, right? Think about the operatory. Every single instrument you use, explorers, mirrors, handpieces, forceps, you name it, can potentially get contaminated with a patient's saliva, blood, oral microbes.
Absolutely.
And if those instruments aren't properly cleaned and then disinfected or ideally sterilized between patients, they become fomites. They become capable of transmitting microbes from patient A to patient B or even from a patient to a member of the dental team. And it's not just instruments, right? Environmental surfaces too. The chair, the countertops, the light handle, anything touched during treatment can become a fomite if it's not disinfected properly.
You've hit it exactly. Understanding that a seemingly inert object can become a vehicle for disease transmission is precisely why rigorous surface disinfection protocols and meticulous instrument cleaning and sterilization are absolutely non-negotiable daily routines. You are directly, actively breaking that chain of indirect contact transmission via fomites every time you do it correctly.
Okay. Next mode is inoculation, or injection.
This mode involves the direct introduction of microorganisms straight into the host's tissues, basically bypassing the natural protective barriers of skin and mucous membranes. The source gives examples like tetanus spores getting into a deep puncture wound, the rabies virus being transmitted through an animal bite that breaks the skin, or blood-borne pathogens like HIV, Hep B, Hep C being transmitted via contaminated needles, syringes, or blood products.
And this is highly relevant in dentistry because of the routine use of needles for local anesthesia and also the ever-present risk of sharps injuries. A needle stick injury, even a tiny one, is a direct inoculation event, potentially introducing whatever pathogens might be in the patient's blood or saliva directly into the dental professional's tissues.
It's a direct breach of the body's defenses. Understanding this mode reinforces why things like using safety-engineered needles, following strict protocols for handling and disposing of sharps, and just being constantly mindful of where your fingers are during procedures with sharp instruments. Why all that is so critically important.
Makes sense. Ingestion is next consuming contaminated food or water.
Yes, this is the main route for pathogens that primarily cause gastrointestinal infections. The source lists examples like cholera, typhoid fever, various bugs causing food poisoning, hepatitis, A virus, poliovirus, all acquired by swallowing contaminated stuff. They get in through the mouth and set up shop in the gut.
Probably less of a direct concern during patient care in the operatory itself compared to contact or aerosols, unless maybe you're dealing with oral signs of a gut infection.
Generally, yes. The primary transmission battleground in the dental clinic involves the other routes, and one of the most significant of those is inhalation.
Breathing in germs. The source specifically mentions droplet nuclei. What are those exactly?
Droplet nuclei are tiny particles, typically less than 5 micrometers in size. They're generated when an infected person coughs, sneezes, talks, even just breathes out forcefully. Because they're so small and light, they can remain suspended in the air for long periods, sometimes hours, and they can travel quite far on air currents.
And the diseases spread this way are serious ones listed in the source. Measles, influenza, whooping cough, tuberculosis, this mode. This has got to have extreme daily relevance in a dental clinic, right? Because so many procedures generate aerosols.
Oh, absolutely. Using high-speed handpieces, ultrasonic scalers for cleaning teeth, the air-water syringe, even polishing. All these routine dental procedures create a dense cloud of aerosols and spatter.
And that cloud isn't just water, is it?
Not at all. It's a mixture. It contains water from the equipment, air, but also saliva, potentially blood, microorganisms from the patient's mouth, maybe tiny bits of tooth dust or filling material. It's a real soup. And those aerosols can hang in the air in the operatory for a significant amount of time and easily be inhaled by the dental team or even by the next patient if the air isn't cleared properly. Understanding that you are, in many procedures, actively creating a potentially infectious cloud. That's precisely why respiratory protection, like wearing proper masks, and eye protection like goggles or face shields, and having good ventilation in the clinic. Why these things are not just suggestions, they are essential barriers against this airborne transmission route. It's a primary way pathogens can get from the patient's mouth right into your own respiratory system.
Very clear. The source also mentions vectors, again, under modes of transmission arthropods transmitting disease.
Right, transmitting either mechanically, like a fly landing on feces and then on food, or biologically, where the pathogen multiplies inside the vector, like malaria in mosquitoes. Again, probably less directly relevant to your day-to-day clinical practice in most places, unless you happen to work where vector-borne diseases are very common and might present with oral symptoms or pose specific risks, but it completes the picture of the diverse ways microbes can travel.
And finally, the source categorizes transmission based on the relationship between the people involved. Congenital or vertical transmission and horizontal transmission.
Congenital or vertical transmission is specifically the passage of an infectious agent directly from a mother to her fetus during pregnancy, across the placenta, or to the newborn during birth, or possibly through breastfeeding. The source gives examples like rubella virus, HIV, hepatitis B, and the bacteria causing congenital syphilis being passed this way.
And horizontal transmission is basically everything else. Person-to-person spread that's not mother to child.
Pretty much. It covers most of the other modes we just talked about: contact, inoculation, ingestion, inhalation. It just draws a line between that intergenerational spread and transmission happening within a generation or between unrelated individuals.
So mastering this whole section on transmission, it feels absolutely foundational for infection control, doesn't it? If you know the reservoirs, and especially if you know the modes, how the microbes actually move from A to B, then you can implement specific, targeted strategies to break that chain. Hand hygiene stops contact transmission. Gloves and masks are barriers. Sterilization kills microbes on fomites. Safe sharps handling prevents inoculation. Managing aerosols deals with inhalation. These aren't just random rules. There's specific interventions designed to block the specific transmission pathways that sources like this one identify.
That's the science behind staying safe and keeping your patients safe in what is inherently a high-risk environment.
Okay, so we've covered where microbes live, the reservoirs, and how they travel the modes of transmission. But once they actually get to a susceptible host and manage to get inside, what decides whether that microbe just gets wiped out by the immune system, maybe lives there harmlessly, or actually manages to establish itself and cause damage, leading to disease? This is where the source brings in the concept of virulence factors.
Right. Virulence itself is basically the measure of a microbe's ability to cause disease. It's pathogenicity. The source describes it as a quantitative measure, meaning some microbes are more virulent than others. Highly virulent ones might cause disease even if only a few organisms get in. Sometimes this is measured by things like the ID50 or LD50, the dose needed to infect or kill 50% of test subjects, though the source just generally refers to the number of organisms needed.
Okay, and virulence factors are the specific tools or traits the microbe has that help it do that, help it cause disease.
Exactly. They are the specific molecules, structures, or strategies that a pathogenic microbe possesses that enhance its ability to, first, establish an infection, second, overcome the host's defenses, and third, cause damage. The source explicitly says these are typically gene products. They're encoded in the microbe's DNA.
So they're like the microbe's arsenal, its weapons.
That's a great way to think of it. They're the specific tools that give it an advantage in that battle with the host. And the source lists several key types of these virulence factors.
First one mentioned is capsules.
Right. These are often a kind of slimy or gummy layer that surrounds the outside of the cell wall of certain bacteria. The source specifically calls out capsules on bacteria like Streptococcus pneumonia, a major cause of pneumonia, Neisseria meningitidis, a cause of bacterial meningitis, and Haemophilus influenza, causes various infections, including ear infections and meningitis.
And what do these capsules do for the bacteria?
According to the source, their main job is to help the bacteria evade phagocytosis.
Phagocytosis, that's when our immune cells, like macrophages, basically eat the invading microbes, right?
Exactly. The capsule makes the surface of the bacterium slippery and physically difficult for those immune cells to grab onto and engulf. The source makes the important point that if a bacterium loses its ability to make a capsule, its virulence often drops dramatically because now the host's immune system can clear it much more easily.
So the capsule is like a primary defense mechanism for the microbe, helping it dodge the host's first responders.
Precisely. It buys the microbe crucial time to multiply before the more specific parts of the immune system can really kick in.
Okay. Then the source gets into toxins. These often seem to be responsible for the really dramatic symptoms we associate with infections.
They often are. Toxins are potent substances produced by microbes that directly harm host cells or interfere with normal body functions. The source makes a key distinction between two major types: exotoxins and endotoxins.
Let's start with exotoxins. The source says these are proteins.
Yes, they are proteins that are actively secreted out of the bacterial cell into the surrounding environment or tissues. The source gives some classic examples: diphtheria toxin, which shuts down protein synthesis in host cells; cholera toxin, which causes intestinal cells to pump out massive amounts of water, leading to diarrhea; and alpha toxin from Clostridium perfringens, which damages cell membranes.
And these exotoxins are potent.
Extremely potent, the source emphasizes. Tiny amounts can cause significant damage, sometimes even fatal. They also tend to be strong antigens, meaning they provoke a strong immune response. That's why we can make effective vaccines against some of them by using inactivated toxins called toxoids, like the diphtheria and tetanus vaccines implicitly mentioned. Some exotoxins, like certain streptococcal toxins called superantigens, cause a huge non-specific overreaction of the immune system, leading to fever, shock, and widespread inflammation.
So exotoxins are like specific, secreted weapons with distinct targets or mechanisms.
Generally, yes. Now contrast that with endotoxins. These are different. They are not proteins actively secreted by living bacteria. Instead, they are structural components of the bacterial cell itself. Specifically, endotoxin is the lipopolysaccharide, or LPS, found in the outer membrane of gram-negative bacteria.
Only gram-negative.
Primarily, yes. That's where LPS is a major structural component. And the source notes that endotoxin is released mainly when the bacterial cell dies and breaks apart when it lays.
Okay, and what kind of effects does endotoxin cause? Is it specific like exotoxins?
Generally, no. Unlike the often very specific actions of exotoxins, endotoxin tends to cause more generalized systemic effects. When LPS gets released into the bloodstream or tissues, it strongly stimulates host immune cells, causing them to release a flood of inflammatory mediators. This whole cascade leads to symptoms like fever, a dangerous drop in blood pressure, hypotension, potentially shock, and just a general state of inflammation throughout the body. The source also mentions that endotoxins are less antigenic than most exotoxins, harder to make vaccines against, and they are very heat stable. Routine heat sterilization might not destroy them.
Why is understanding this difference, especially about endotoxin LPS, so critical for a dental student? You emphasize gram-negative bacteria.
Because LPS from gram-negative bacteria is absolutely fundamental to the development and progression of periodontal disease. Periodontal disease, as you know, or we'll learn in detail, is all about chronic inflammation of the gums and the bone supporting the teeth. And the source implicitly connects this by highlighting that gram-negative bacteria are key players in the dental biofilm, the plaque, found in those periodontal pockets between the tooth and gum. As these bacteria live, grow, and eventually die and lies within that biofilm, their LPS is constantly being released right there in the gum tissues.
Oh, okay.
This LPS is an incredibly powerful trigger for the host's inflammatory response in those tissues. Now, initially, that inflammation is trying to be protective, trying to fight the bacteria, but because the biofilm is persistent, that LPS release is chronic. And chronic inflammation, driven by LPS, is what ultimately leads to the destruction of the periodontal ligaments and the alveolar bone, the very things that hold teeth in place. So understanding endotoxin isn't just academic, it's key to understanding the mechanism of tissue breakdown in one of the main diseases you'll be treating constantly.
That's a really direct link from a molecular detail in the source to a major clinical problem. Okay, what's the next virulence factor on the list?
An absolutely critical one for understanding how infections even start. Adhesins. These are molecules or structures on the surface of a microbe that allow it to stick or adhere specifically to surfaces. That could be host cells or tissues, or even inanimate surfaces like dental implants or dentures. The source mentions things like pili or fimbriae. Those are like little protein hairs on bacteria, or extracellular polysaccharides, sticky sugar-based molecules as examples of adhesins.
And the source makes a very strong point about how important adhesion is.
It really does. It explicitly states that adherence is the essential first step for colonization and initiating infection for many, many pathogens. Think about it. If a microbe can't stick to a surface in the body, especially in places with fluid flow like the mouth or the urinary tract, it's likely to just get washed away by host defenses, saliva flow, mucus movement, urine flushing.
So no stick, no infection.
For many pathogens, yes. The source points out that bacterial mutants that have lost their ability to make their specific adhesins are often completely non-pathogenic. They just can't get a foothold.
How does this connect directly to dentistry? It seems pretty fundamental.
Oh, it's profoundly connected. The source specifically gives the example of the bacterium Streptococcus mutans adhering to the enamel surface of teeth. This initial attachment, using adhesins, is the absolute critical first step in forming dental plaque, which, remember, is a biofilm.
Right.
S. mutans and other early colonizers used their adhesins to first bind to the acquired pellicle, that thin film of proteins from saliva that coats your teeth, and then they bind to each other, building the initial structure of the plaque biofilm that ultimately leads to cavities. The source also mentions other examples, like pili helping E. coli stick to the urinary tract lining, which illustrates how specific these adhesins can be. They often only bind to certain types of host tissues. In dentistry, this tissue specificity explains why different microbes prefer to live on different surfaces in the mouth, the tongue versus the tooth surface versus deep in a gum pocket. It all depends on their adhesins matching the receptors available there.
So adhesion isn't just an important factor. It's often the necessary precursor for everything else the microbe might do, especially in the mouth where things are constantly being rinsed by saliva and scraped by chewing.
Absolutely. Without sticking, most oral pathogens simply couldn't colonize long enough to cause trouble or form those complex plaque communities.
Okay, so after sticking, some microbes have the ability to actually spread through tissues. The source calls this invasiveness.
Right. Invasiveness is the ability of a pathogen to spread beyond its initial site of attachment and penetrate into deeper tissues. The source mentions that this ability is often boosted by the microbes secreting certain enzymes that break down the components of the host's extracellular matrix, the scaffolding between cells and connective tissues. Examples given are enzymes like collagenase, which digests collagen, a major protein in connective tissue and bone, and hyaluronidase, sometimes called the spreading factor, which breaks down hyaluronic acid, a sort of cementing substance in tissues.
How does invasiveness play out in dental infections?
Think about how an oral infection can progress. Maybe you have a localized abscess at the root tip of a tooth or a really deep periodontal pocket infection. It starts in one spot. But if the bacteria involved possess these invasiveness factors, they can secrete enzymes that start dissolving the surrounding bone matrix, which contains collagen, and the connective tissue.
Yeah.
This allows the bacteria, along with pus and inflammation, to literally spread through the jawbone, maybe into the adjacent soft tissues, or even into the fascial spaces of the head and neck. These spreading infections, things like facial cellulitis or the very serious Ludwig's angina, they happen because the microbes are invasive. Understanding invasiveness helps explain how a seemingly small, localized dental infection can sometimes rapidly spread and become a much bigger, potentially life-threatening systemic problem.
So it's like the microbe's ability to tunnel or dissolve its way through barriers to get to new territory.
That's a good analogy. They essentially create their own pathways for spread. The source also mentions other secreted enzymes that contribute to virulence in different ways. Yes, besides the ones involved in invasion, it gives examples like coagulase, which is famously produced by Staphylococcus aureus. Coagulase causes blood plasma to clot. The thinking is this might help the bacteria wall themselves off inside a little fibrin clot, protecting them from immune cells.
Hiding in a self-made clot. Clever.
Kind of. Another important group mentioned are IgA1 proteases. These are enzymes produced by various pathogens that like to colonize mucosal surfaces. The source lists bacteria like Neisseria gonorrhoeae, Neisseria meningitidis, Haemophilus influenza, and Streptococcus pneumonia, many of which affect the respiratory tract and could be relevant to aerosol transmission. What these enzymes do is specifically chop up and inactivate IgA1.
And IgA1 is?
It's a type of antibody that's really abundant on our mucosal surfaces, like in saliva, tears, respiratory secretions. It's a key part of our first-line defense there. So, by destroying IgA1, these bacteria can colonize those surfaces more easily. The source also mentions hemolysins, which are enzymes that damage or lyse red blood cells.
These enzymes really sound like targeted biochemical weapons, designed to disrupt specific host defenses or damage host cells directly.
They really are. They help the microbe survive, get nutrients, and spread. Now, beyond capsules and enzymes, microbes also have some pretty sophisticated strategies for more actively avoiding host defense mechanisms. The source briefly touches on this, mentioning things like antigenic variation. This is where pathogens like the influenza virus or HIV are famous for this, rapidly change the structure of their surface molecules, the antigens that the immune system recognizes. By changing their coat, they make it really hard for the host's immune system to keep up and mount a lasting, effective antibody response.
Changing disguise constantly.
Exactly. Another strategy mentioned is intracellular survival. Some pathogens, like Mycobacterium tuberculosis, which causes TB, have evolved the ability to live and even multiply inside host cells, often inside the very immune cells like macrophages that are supposed to kill them. By hiding inside cells, they're protected from antibodies and other immune components circulating outside cells.
So they actively adapt or hide to survive the onslaught.
Yes, it really highlights this constant evolutionary arms race between the host and the microbe. Now, while all these factors are important, there's one virulence factor described in the source that, from the perspective of day-to-day clinical dentistry, is arguably the single most impactful: biofilms.
Yes, biofilms. The source explicitly discusses these as a key virulence factor.
It does, and this is hugely relevant for you. The source defines biofilms as complex, structured communities of microorganisms. They're not just floating around, they are attached to a surface, and they're embedded within a slimy, self-produced matrix. This matrix, often called EPS, extracellular polymeric substances, is usually made of things like polysaccharides, sugars, proteins, and even DNA. They aren't just a random pile of bacteria, they are highly organized, functioning communities.
And the source makes a really critical point about the bacteria living inside these biofilms.
Yes, it states very clearly that bacteria living within a biofilm are significantly more resistant to antimicrobial agents, things like antibiotics and disinfectants, and also more resistant to the host's own defense mechanisms compared to the exact same bacteria when they're floating freely in a liquid, what we call the planktonic form.
Why is this resistance so important, especially in dentistry?
Because, as the source directly points out, with the example of endodontic infections inside the root canal, being primarily caused by polymicrobial biofilms, many of the most common, most persistent, and hardest to treat oral infections are fundamentally biofilm-mediated diseases.
Like what?
Well, dental plaque itself, the stuff that causes cavities and gum disease, is the absolute classic example of a complex polymicrobial biofilm stuck firmly to the tooth surface. The source specifically calls out endodontic infections, and periodontal disease is driven by pathogenic biofilms deep in the gum pockets. Dental caries result from the acid produced by bacteria within the plaque biofilm.
So plaque, cavities, gum disease, root canal infections.
Yep.
These are all caused by these protected, resistant microbial cities.
That's a perfect way to think about it. And this is precisely why treating these conditions can be so challenging. That slimy matrix surrounding them acts as a physical barrier, making it hard for antibiotics or disinfectants to penetrate deep inside and reach all the bacteria. Also, bacteria within the biofilm can exist in different metabolic states. Some might be dormant or slow-growing, making them less susceptible to drugs that target actively dividing cells. Plus, living packed together like that makes it easy for them to share genetic material, including genes that confer antibiotic resistance or other virulence factors.
Which explains why you often can't just cure a deep cavity or clear up significant periodontal disease or sterilize an infected root canal simply by prescribing antibiotics, right?
Exactly. It fundamentally changes the treatment approach. For almost all biofilm-mediated diseases in the mouth, mechanical disruption of that biofilm is the most critical step. Think about toothbrushing and flossing. That's mechanical disruption of plaque. Scaling and root planing for periodontal disease, you're physically scraping the biofilm off the root surfaces. Root canal therapy, a huge part of it is mechanically cleaning out the infected tissue and biofilm from inside the tooth and irrigating to flush it out. You have to physically break up that protected community to expose the bacteria underneath to the host's defenses or to allow antimicrobials to actually work effectively. Understanding the biofilm as a core virulence mechanism is absolutely foundational to understanding why these common oral diseases persist and why they resist treatment.
It really shifts the focus from thinking about individual free-floating bacteria to dealing with these organized, fortified microbial communities living on surfaces.
Highly fortified cities is a good image. Okay, one last category of virulence factors the source mentions: plasmids and bacteriophages. Right. These aren't virulence factors themselves, but they are vehicles for spreading virulence genes. Plasmids are small, usually circular pieces of DNA that exist separately from the main bacterial chromosome. They can replicate on their own, and partially can often be transferred from one bacterium to another, sometimes even between different species, through processes like conjugation. Bacteriophages, or just phages, are viruses that specifically infect bacteria. When they replicate, they can sometimes accidentally pick up pieces of the bacterial DNA and carry them to the next bacterium they infect, a process called transduction.
And the source says these mobile elements can carry important genes.
Yes, they can carry genes that encode virulence factors. The source gives the example of the diphtheria toxin gene actually being carried by a bacteriophage. Critically, they can also carry genes for antibiotic resistance.
So this means microbes aren't static. They can actually acquire new weapons like stronger toxins or resistance to antibiotics from other microbes they bump into, and these traits can then spread rapidly through the bacterial population.
That's exactly right. It adds this whole layer of dynamic complexity to the microbial world. It helps explain how virulence traits and antibiotic resistance can evolve and spread so effectively within bacterial communities, including the complex ones living in the oral cavity.
Wow. So understanding this whole suite of virulence factors, the capsules that hide them, the toxins that damage, especially that LPS linked to periodontal disease, the adhesins that let them stick in the first place, the invasiveness that lets them spread, the specific enzymes that break things down or fight defenses, the ways they actively avoid the immune system, and especially the huge significance of biofilms. It gives us the blueprint for how microbes actually cause disease. It explains why some are nastier than others, and, really importantly, it guides how we approach treatment by identifying what we might be up against, like needing to physically disrupt a biofilm instead of just relying on drugs.
It's like knowing the enemy's playbook, their strategies and weapons.
Okay, finally, our source material wraps up by talking about how these infections actually manifest clinically in the body, the different ways they can present as resulting diseases. This kind of brings us full circle back to the clinical outcome after the microbe has successfully gotten in, navigated transmission, used its virulence factors, and established itself.
Yeah, this last section really focuses on describing the clinical picture, especially in terms of how widespread the infection becomes within the host.
We briefly touched on localized versus generalized infections earlier when we were classifying the types of infection, defining them by whether they stayed put or spread. The source comes back to these concepts here, framing them now more explicitly as types of infectious diseases.
Right. A localized infection is described as a disease process that stays restricted to a specific anatomical site. As the source mentions, this could be superficial, like that staph boil or cellulitis on the skin, or it might be deep-seated but still confined, like appendicitis or pneumonia affecting just one part of the lung. And as we discussed, many common oral infections, think dental abscesses, gingivitis, they start out as localized diseases.
And understanding the factors that help keep it localized, like a strong immune response walling it off, or maybe the microbe just doesn't have strong invasiveness factors versus the factors that allow it to spread, like those invasiveness enzymes, or maybe a weakened host that's key to managing them, right?
Precisely. The integrity of the body's anatomical barriers and the effectiveness of the local immune response are critical for containing these localized infections.
And then there's the opposite. Generalized or systemic infection. This is where the pathogen, or sometimes just its toxins, spread throughout the entire body from that initial starting point.
And the source details different levels or degrees of this systemic involvement. It presents them almost as a hierarchy of increasing severity, which is a really crucial concept for understanding potential complications, especially from seemingly local infections.
The first level described is bacteremia.
Bacteremia is defined simply as the presence of bacteria in the bloodstream. Now, the source makes two very important points about bacteremia. First, it usually involves a relatively low number of bacteria. Second, it's often clinically insignificant, meaning it doesn't necessarily cause symptoms or problems. And here's a piece of info with huge implications for dentistry. The source explicitly states that transient bacteremia, meaning temporary presence of bacteria in the blood, can happen even in perfectly healthy people during a completely normal everyday activities.
Like what?
Like brushing your teeth, chewing food, even using dental floss.
Wow, really? Just brushing your teeth can push bacteria into your bloodstream.
According to the source, yes. Think about it. The mouth has a huge number of bacteria, and activities that slightly disturb the gum tissues, even just the minor trauma from brushing or flossing, can allow small numbers of these oral bacteria to enter the tiny blood vessels right there in the gums.
Okay.
But in a healthy person, the immune system's phagocytic cells circulating in the blood, plus organs like the spleen and liver that filter the blood, quickly recognize and eliminate these bacteria. So the bacteremia is transient, short-lived, and usually completely harmless.
So just finding bacteria in the blood isn't automatically a disaster, especially if it's only temporary and low level.
Not at all. It seems to be a fairly common physiological event. The real concern arises when the number of bacteria getting into the blood is high, or when they have ways to evade this rapid clearance, or perhaps most importantly, when the host's immune system is compromised and can't clear them effectively. And that leads us to the next level of systemic involvement described, which is much more serious: septicemia.
The source calls septicemia sepsis of the blood.
Yes, and it represents a much more severe and clinically significant state than just transient bacteremia. In septicemia, large numbers of bacteria don't just get into the bloodstream, they actively multiply and persist there. They're setting up shop in the blood. The source notes that this triggers a massive systemic inflammatory response from the host, leading to clear clinical signs and symptoms, things like high fever, shaking chills, rigors, increased heart rate, rapid breathing, confusion, and often a dangerous drop in blood pressure, which can lead to shock. It signifies a failure of the host's defenses to control the bacteria within the circulatory system.
So bacteremia is just bacteria present, often briefly and in low numbers. Septicemia is bacteria actively multiplying and persisting in large numbers in the blood, causing a systemic illness mainly due to the host's overwhelming inflammatory response to those circulating bacteria and maybe their toxins like endotoxin.
That's a very good summary. It's an active, life-threatening infection spreading through the circulation. And then there's one more level described in this hierarchy, the most severe: pyemia.
Pyemia. That sounds particularly nasty, with the pie suggesting pus.
It is. Pyemia is defined as septicemia that gets complicated by metastatic infection. What this means is that the bacteria circulating in the blood during septicemia have successfully landed in distant sites throughout the body and started new infections there, leading to the formation of multiple abscesses, those localized collections of pus and infected tissue in various internal organs. The source gives examples like the spleen, liver, and kidneys developing these secondary abscesses.
So the bacteria traveling in the blood essentially set up new pockets of infection far away from where the original infection started. It's systemic spread resulting in new, distinct spots of localized disease all over the body.
Exactly. It represents a very advanced and dangerous stage of systemic infection, often associated with pathogens like certain types of staphylococcus that are particularly good at forming abscesses.
Understanding this whole hierarchy, from transient, usually harmless bacteremia, which again the source says can happen just from brushing teeth or routine dental work, all the way up to severe, multiplying septicemia, and potentially pyemia, with abscesses popping up everywhere, this seems incredibly important for you as a future dental professional to grasp.
It really is.
It directly explains the potential systemic consequences of infections that start in the mouth. While that transient bacteremia from dental procedures is usually handled fine by healthy patients, knowing it happens is critical for assessing risk, especially for patients who might have underlying conditions like certain heart problems or artificial joints, where even that temporary seeding of bacteria could, theoretically, pose a risk of causing a serious infection at that distant site. Now, the guidelines on when to give antibiotics prophylactically for dental procedures are complex and constantly evolving, but the fundamental concept from the source that oral manipulations can cause bacteremia is the reason those guidelines exist and why that risk assessment is so important.
It provides the scientific rationale for appreciating that crucial link between oral health and overall systemic health. It highlights why effectively managing infections in the mouth isn't just about saving teeth, it's potentially about preventing much more serious, body-wide complications down the line.
Okay, wow. We have covered a massive amount of ground today, all guided by this source material. We kick things off by establishing that really fundamental difference between infection, just the presence and multiplication of microbes in infectious disease, which is the less common outcome, where that infection actually causes clinical symptoms, often driven by toxins and inflammation.
Right. Then we systematically went through the diverse types of infection described. We learned how to classify them by their origin, their timing, their pattern of spread, everything from that first primary encounter to secondary infections that take advantage of weakness, the critical idea of cross-infection happening in the clinical setting, those sneaky latent infections like oral herpes that can hide and come back, and also the population-level view with endemic, epidemic, and pandemic spread.
We then follow the microbe's journey, starting with its reservoir, and diving deep into the crucial modes of transmission. We really unpacked how contact, both direct touch and indirect via those critical fomites, like dental instruments, plus inoculation, through things like needle sticks, ingestion, and especially inhalation of those aerosols produced during dental work. How these are the pathways microbes use to get from place to place, or person to person. Mastering these transmission routes, as we said, that's the absolute scientific foundation for effective dental infection control.
And we spent a good chunk of time unpacking the microbe's formidable arsenal, its virulence factors, the tools that let it cause harm. We talked about capsules that help evade immune cells, powerful toxins like the gram-negative LPS, which is so important in understanding periodontal disease, the absolutely essential first step of adhesion that kicks off things like cavity formation and plaque buildup, the invasiveness factors that allow infections to spread through tissues, other specific enzymes, the clever ways microbes actively avoid the immune system, and maybe most importantly for dentistry, the incredible significance of biofilms. We really hammered the source's point about how resistant biofilms are to antibiotics and defenses, making them central to the persistence of plaque, cavities, gum disease, and root canal infections.
And finally, we looked at how these infections actually show up as diseases in the body, outlining the difference between localized infections, like those often starting in the mouth, and the escalating severity of systemic involvement from that often harmless transient bacteremia, which can come from just brushing, up to dangerous septicemia, where bacteria multiply in the blood, and the severe complication of pymia with spreading abscesses.
This whole deep dive, really using the source material as our map, has hopefully provided you with a really comprehensive foundational understanding of this microbial world and how it interacts with us, the hosts, specifically tailored to the challenges and, frankly, the responsibilities you're going to face in your dental career.
It is truly vital knowledge. It's the language you'll use every day, the risks you'll constantly assess, the processes you'll need to manage meticulously, everything from implementing bulletproof infection control protocols to diagnosing different oral diseases, understanding how they might progress, appreciating those potential links to overall body health, and just recognizing that intricate dance happening constantly between the diverse microbial communities living in the mouth and the host self.
Yeah, you're essentially training to become an expert choreographer for that dance within the oral cavity.
Our source really highlights how infections, even ones that seem simple on the surface, involve this incredibly complex back and forth between the microbe and the host. It's a delicate balance, constantly influenced by host resistance on one side and microbial virulence on the other. And that line between just having microbes present infection and actually developing disease, well, it's often pretty thin, easily tipped one way or the other by shifts in that balance.
Indeed, it's never static, always dynamic.
So here's a final provocative thought for you to maybe chew on as you continue your studies and get ready for practice. Given everything we've discussed from the source especially, that the oral cavity is one of the most densely packed microbial environments in the body, a major doorway for microbes entering, and a prime location for forming those super-resistant biofilms, how does that constant, intricate balancing act between the microbes living there and the host's defenses influence not just a person's oral health over their lifetime, but potentially their overall systemic well-being too? Considering the potential for transmission, toxin release, bacteremia, and inflammatory impacts that our source described.
It really suggests the mouth is far more than just a collection of teeth and gums, doesn't it? It's a critical dynamic interface where the body is constantly negotiating its relationship with the microbial world, with potential consequences reaching far beyond the local environment.
A fascinating connection and one you'll be dealing with directly. Thanks so much for joining us for this deep dive.
Our pleasure. There's always more to explore just beneath the surface.